our sessions. Now we go the second part, which will be about the, we got to start with, come back with Dr. Stephen, because he got to give a talk in non-invasive neuroimaging technique for diagnosing and studying neuropathology in neurological and neuropsychological disorder. I have already give you the little bit bibliography about Dr. Stephen. He's an outstanding neurologist that worked in this topic in Florida a long time ago, and he has many experience. He's like an encyclopedia in neurology. I have a chance to have a dinner with him yesterday, and we talk about many projects, which is nice to have him in the podium. Welcome and have a video. The podium is for you. Thanks.
Thank you so much. Well, first I want to say that as I was perusing the program this morning, I counted representatives from 17 countries. I was stunned, and all over the world, including Professor Sodov. Is she here? From Mongolia? I thought, my God, you know, isn't this wonderful that people, even from countries that we thought there was nothing there, have joined us in this noble pursuit of science. This is great. This is just terrific. So I appreciate every one of you, and I'm so glad that you can, that there's an infrastructure in your countries to start developing your own science. So this is great. So this talk, and I imposed on a little to change the time. So if you're irritated about the change in the schedule, you can blame me. But I didn't want you to forget what I talked about this morning. And of course, I'm counting on all of you to have photographic memories and you remember every slide I presented, but it's okay. Hopefully we'll patch this together. So there are two themes here. One is when I first started studying emotions, and there'll be a section on depression, started about 5 years ago when my mentor, colleague, Kenneth Heilman, was invited to edit a volume of the Handbook of Clinical Neurology entitled Emotional Manifestations of Neurologic Disease. And I've lived most of my career in the left hemisphere, I have to say. I had familiarity with a lot of these processes mediated predominantly by the right hemisphere. But I thought, well, you know, I have some really powerful conceptual tools, most particularly PDP. And surely, if I look at these problems through the PDP lens, I'll be able to bring some order. And lo and behold, I think I succeeded, and hopefully I'll convince you of that today. There's a longer range issue here, and that is that Sigmund Freud was a neurologist. We all think of him as a psychiatrist, but he was a neurologist too, and actually at the turn of the 19th century contributed some very good papers on aphasia. He often gets dwarfed by contributions to people like Wernicke and Lissauer and so on, but nevertheless, he made important contributions. Now, his theory, his psychoanalytic theory, is, I'll call it, pseudo-anatomic. It's really hard to relate his major variables to specific regions of the brain, but it's pseudo-anatomic. And so when I look at it, I think this is clearly the product of a neurologist, because neurologist's home is anatomy. And one of the things that happened, psychoanalysis continued in its flourish well into the 1970s, and then you know, there were links to neurology, were still boarded by the same organization. But then with the advent of biological psychiatry, it kind of parted ways. So neurologists remained anatomists, and psychiatrists, you know, I've sometimes say kind of snarkily that for psychiatrists, the brain is a big container of some soup laced with dopamine and serotonin and acetylcholine, and you manipulate these things, and that's how you treat psychiatric disease. But what I see here is actually there is anatomy here, and we can use an understanding of the anatomy of emotion and of psychiatric disease to help us to understand that better and to treat it better. So if you want a reference, it's in this paper in Handbook of Clinical Neurology. So I suspect all of you don't have photographic memory, so I'll just quickly go over what we talked about. With the PDP approach, it's based on nonlinear neurodynamics, nonlinear properties. Its function is probabilistic or stochastic, and it's an example of one little field of chaos. The theory is based on some very simple assumptions, population encoded representations, so representations corresponding to activity of millions or billions of neurons. The knowledge is in the connections of the synapses, and learning corresponds to changes in the strengths of those synapses. The theory posits two kinds of networks, auto-associator networks and pattern-associator networks, and there's very good evidence that, yeah, the brain recognizes that. And in particular, I point out that, we see white matter pathways and we just see the wires that connect two areas, but actually they're probably better viewed as pattern associators. So, people in the functional imaging field often say, well, there's semantic representation in Broca's area, and defend it on the basis of connections between supramarginal gyrus and angular gyrus in Broca's region. But what they're leaving out is back in supramarginal gyrus and angular gyrus, those are semantic concept representations, but because it's a pattern associator, by the time we get to Broca's region, they're phonologic sequences. They've been transformed because a pattern associator is involved. Even simple concepts like dog have multifocal representations, and I'd like to think that I've convinced at least some of you that even thinking about very simple things, we engage our whole brains, and I'm going to reiterate that concept here because we're going to bring in some other systems that are crucial to our global brain processing. Processing the brain consists not of transmission of information from one area to another, but to this simultaneous settling within constellations of attractor basins into attractor states, thereby accomplishing parallel constraint satisfaction. Okay, so let's take a high helicopter view of brain function. Dorsolateral frontal cortex is where the action is. So that's where behavior originates, heavy projections to premotor and motor cortex. And if behavior is not actualized, then it's thinking. And that's the domain of dorsolateral frontal cortex. But it gets a tremendous amount of advice, of input. So largely post-central cortices provide information on objective, so perceptions at that particular moment, memories. So basically the factual input to dorsolateral frontal cortex that is serving to drive behavior. It also gets heavy input from orbitofrontal cortex, and orbitofrontal cortex provides the substrate for our subjective knowledge. And I don't think most people think very much about this, that the role of subjective knowledge in our daily lives, and the idea that we accumulate subjective knowledge through a lifetime of experiences, possibly even starting in utero. So let me just lead you through some homely examples here. So you get up in the morning, or you wake up. Should you get up? Why should you get up? Well, you got a job and a career. Subjective value. Okay, so you decided to get up. Take a shower. Why should you take a shower? Well, because you'll stink. Subjective value. You take a shower, now you got to make a choice about clothes, right? Or to wear clothes at all. Why can't you just go out naked? Climate allowing, subjective value. And then you got to make a choice of which clothes you're going to. So it pretty much every moment we're bringing subjective value into this conversation in dorsolateral frontal cortex. So we're depending on both in everything we do, everything we think about, we're bringing into play subjective value from orbitofrontal cortex and linked limbic structures like amygdala and hypothalamus and all the way down to the interstitial nucleus of the rostral interstitial nucleus of the MLF, all kinds of these limbic structures that are brought to bear. We're also communicating with the hippocampus, again, this back and forth settling, because the hippocampus contains information that has not been encoded in the cortex. So it's acquired knowledge, subjective or objective, that is either going to eventually be consolidated to the extent that it shares features with knowledge in the cortex, or it may remain permanently hippocampally dependent. And a very good example of that is autobiographical memory. So there's plenty of case reports out there of patients who suffered anoxic damage and severely damaged much of the cells in the cornu-ammonis, and their autobiographical memory was gone. It was completely gone. So, but most of the things that we learn, most of the fact memories we acquire will eventually be incorporated in the cortex, and then they'll be hippocampally dependent, but we're still bringing those half-baked episodic memories to bear in the formulation of behavior or thinking in dorsolateral cortex. Okay, so let's talk a little bit about orbitofrontal cortex. This is kind of neglected territory. Edmund Rolls, who's at Oxford right now, has spent much of his career studying orbitofrontal cortex, much of it in single unit recordings in macaque orbitofrontal cortex. And he's defined two major areas. The neurons in medial orbitofrontal cortex respond predominantly to reward, and neurons in lateral orbitofrontal cortex respond predominantly to either punishment or failure to receive expected reward. So as I thought about this, it seemed like, okay, here's the anatomic and physiologic basis for two large attractor basins. We can do a thought experiment and recognize that there are probably many subbasins and subbasins. So medial orbitofrontal cortex might support happiness, joy, delight, pleasure, love, pride, humor, sense of accomplishment, all of those positive emotions. The lateral orbitofrontal cortex might support sadness, fear, anger, disgust, terror, horror, and so on. But there's also subbasins, as we saw in the big mammal manifold. So there's different kinds of sadness. There's a sadness of inconsolable grief. There's a sadness evoked by historical events. We've got the planet is in a particularly sad situation right now. Sadness evoked by human suffering, cyclothymia, or just disappointment, all kinds of degrees and flavors of sadness that have correspond to attractor basins and attractor states in orbitofrontal cortex. And there's some dual representation. So the emotion of bittersweetness. For me, it's typically a mentee or valued colleague who tells me they're leaving, they're moving on to another university, and I'm really delighted that they're they've gained so much at this by institution that they're able to move on with their career. It's great, but I'm really going to miss them too. So two emotions, positive and negative at the same time. So both of those big attractor basins are engaged. Okay, now what about connectivity? Well, I mentioned in my last talk that we have excellent confirmation that in the cortex of at least higher subhuman primates like macaque, and in humans, that all connections in the cortex are reciprocated. So they're all communicating with each other, linking back and forth to these successive volleys of neuronal firing that eventually lead to settling in an attractor state. What about orbitofrontal cortex? Well, there's plenty of connectivity between orbitofrontal cortex and dorsolateral frontal cortex. Certainly, as Edmund Rolls has pointed out, connectivity that's through subgenual cingulate, subgenual anterior cingulate, which is kind of, you could think of as the limbic ventral extension of the whole cingulate complex, and it's heavily interconnected with pregenual and supragenual cingulate, and probably important to our final decision, given multiple behavioral options, to pick one and go with it. Not that the decision is actually made there, because many other parts of the cortex are weighing in, but it finally materializes a particular choice in that region. There's also extensive connectivity via the frontal pole. So fast connectivity between frontal pole and dorsolateral frontal cortex and orbitofrontal cortex. So we could usefully, at least for now, think of frontal pole as a hidden unit region that is facilitating the computational process that takes place between orbitofrontal and dorsolateral cortex in computing action plans. Are you with me? Okay, now let's talk about some regional things so we better understand the neural basis for emotion. So one dimension, excuse me, I'll just refer to as processing style, because although people have puzzled and made conjectures about the fundamental differences between right and left hemisphere processing, the computational basis for those is still not well understood. I suggested some years ago that in the left hemisphere, we see an unusually large number of pattern associator networks that are instantiating knowledge of sequence. And obviously, sequence knowledge is vital for language and for praxis. Language is phonological sequence, as conceptual sequence, that is syntax. I'm not saying that sequence knowledge only exists in the left hemisphere, but there's certainly striking that it seems to predominate in the left hemisphere. And the right hemisphere we think of as a Gestalt processor, sort of, you recognize somebody's face, and yeah, you can do a left hemisphere shtick and describe individual features that characterize that face. But when you recognize a friend in a crowd, is boom, you suddenly recognize. You take it all in at once. It's a Gestalt process, and we don't really understand that at the neural level. So let's talk a little bit about disorders of the right hemisphere that result in impaired emotional processing. So we're going to start out with convexity cortices, and these have been the emotional problems, mainly problems with emotional communication that result from cortical lesions, have been extensively studied. So in people who have more posterior lesions in the right hemisphere, they have difficulty recognizing emotional expressions and faces, and they have difficulty recognizing the emotionality in spoken language, what's called affective aprosodia. In people with more anterior lesions, it's more problems with expression. So their facial expression and the gestures they use basically become degenerate in the extreme. You see these people in clinic and they're like robots. I mean, they really sound like robots and behave like robots. And they have expressive affective aprosodia. So that's the cortex. What about orbitofrontal cortex? Well, here we're talking about degeneration of a vital substrate for subjective value. And our best human model of that, and it's a horrible model, is behavioral variant orbitofrontal dementia. So people with classic behavioral variant, yes, they have atrophy of bilateral orbitofrontal cortices, but it's predominant in the right side. And these people, I don't know if you've ever met one, but it just breaks your heart, and it gives you the creeps. I mean, these people behave in such noxious fashion in clinic that you're kind of looking at your watch thinking, when can I get out of here? And you're empathizing with the family and the terrible ordeal. So these people, there's some core criteria called Raskowski's criteria, apathy, inertia, what many neurologists, including me, would call abulia, disinhibition, so inappropriate touching, feeling, stuff like that, loss of empathy and sympathy. Often there are changes in diet, hyperorality, so they'll eat everything in sight, anything you put in front of them, and they gain weight. Often they have weird dietary preferences. They may have stereotyped compulsive or ritualistic behaviors. They'll often adopt particular dressing preferences, and very commonly, they always used to be a real snappy dresser, and now they're in a sweatshirt and with no regard whatsoever. There's a whole bunch of other things, diminished emotional recognition, diminished psychophysiologic reactivity to emotional stimuli, reduced emotional expression, this robotic-like behavior. And I won't go through the whole list here, but in some, it's a profound change in personality. So this dementing disorder told us what the neural substrate of personality is. It's predominantly right orbitofrontal cortex. So here's a conundrum. So we've said that the information we have, particularly from animal studies, and Edmund Rolls was studying orbitofrontal cortices in macaque, but macaques don't really have established laterality to their brains, or it's minimally developed. So it really didn't matter whether he's studying left or right orbitofrontal cortex. So to that extent, we don't have a good model for humans. So we're having to puzzle this out from the lesion models we have. We've got a great one here for degeneration of right orbitofrontal cortex, loss of subjective knowledge. But what's the analog in left orbitofrontal cortex? There's only one frontotemporal lobar degeneration that involves degeneration even proximate to orbitofrontal cortex, and it's not really, it's actually a Broca's region. So it's right on the lowest point of the frontal convexity. So we don't really have a model of what happens when you've got generalized degeneration of the left orbitofrontal cortex. And I've been thinking about this, and I honestly don't know, but I'm throwing out a wild conjecture here. So if we look at disease of we look at what the right orbitofrontal cortex does.
Just they drill alarm for a few minutes and it will be stopped. Don't worry about it. Just for fire. It's not anything. Just a few minutes and it will stop.
So if we infer the function of right orbital frontal cortex from all these behaviors of people with classic behavioral variant frontotemporal dementia, we could say that the right orbital frontal cortex is supporting reactive emotion. So it's an immediate emotional response to a particular set of stimuli or a particular set of memories. Okay, and my very speculative hypothesis is that left orbital frontal cortex is supporting emotionality that is proactive and sustained over long periods of time. So interest, curiosity, intrigue, ambition, love, and hate, these transcend particular situations. So, people who feel hate to other people of other races, for example, it extends forever. I mean, this is their curse in their lives. They have this particular subjective knowledge, and it's not just a moment. It may flare up, when they encounter somebody from another race, but it's there. So it's proactive. Now, I haven't figured out the exact, seen a dementing patient who I could say that's what they have. That's the problem they have. But so I said it's kind of a speculative idea. Okay. Now, there's a famous theory of emotion called the James Lange theory. This is William James, a very famous psychologist that has profoundly influenced cognitive neurology and neuropsychology. And his and Lange's theory was that when we experience emotions, it's a result of autonomic outputs, so sympathetic and parasympathetic, which then elicits afferent volleys of information that project to a number of areas in the brain, most particularly to the insula, which can be viewed as the major source of autonomic input to the orbitofrontal cortex. And it's the experience of that afferent input that gives us a feeling of the emotion. And there's a lot of data that has emerged. This is an old theory. There's been a lot of study, and that suggests that, yeah, there's truth to this concept. There's truth, but I think the problem that I see is that it's incomplete because it doesn't talk about orbitofrontal cortex. That wasn't on James and Lange's map. So if we say, okay, we'll take the James Lange theory, but let's broaden it out and include orbitofrontal cortex as one of the players, and in fact, in humans, undoubtedly the major player, to the extent that we're no longer quite sure to what extent a subcortical structure like the amygdala, how much of a role is that playing in our daily experience? And it's an almost impossible question to answer. There are models of pure amygdalar damage in humans, but their behavior is, it's subtly different. It's not like they're sociopaths. Okay, so I've mentioned the amygdala, and so I'm going to talk for a moment about subcortical structures. So there's now a lot of information, and I'll particularly point you to the paper by Fiore and colleagues in Philosophical Transactions of the Royal Society, that the function of the sensory motor basal ganglia is dimensionality reduction. Now, what the heck does that mean? Well, the best example I can think of is a lamprey, which is this sort of very primitive eel-like fish. It's a vertebrate. It looks like an eel, except it has no jaw. It's just the mouth is a round orifice that's lined with teeth. So it turns out that lampreys, they have reasonable vision, they can hear, they have vestibular sense, they have olfactory sense. They have a lateral line organ, so they can detect magnetic fluctuations in the fluctuation in the magnetic field within the water. So they bring this enormous repertoire of complex three-dimensional sensory input to the table. Now, what do they do with that? Well, they swim forwards, they swim backwards, they tip their head up, down, to one side or the other. They can propel themselves forward and glom onto the side of a fish where they start chewing and digesting whatever part of that fish they grabbed onto. They can sow eggs or sperm. That's it. That's their entire behavioral repertoire. And the idea is that the basal ganglia in lamprey are serving to translate that vastly dimensional sensory input into one of just a handful of behaviors in the lamprey's behavioral repertoire. And it really looks like the lamprey departed the human line, the human mammalian line 540 million years ago. So all of this stuff, they have a well-developed basal ganglia, all this stuff developed a long, long time ago. There's reason to think that the basal ganglia, at least the sensory motor basal ganglia, have done noble service in providing the basis for what I'll term reactive intention. That is, you've got a pattern of sensory input and it immediately translates into a particular behavioral output. We use it all the time. So, you get up in the morning, you shower, brush your teeth, half of a shave. Do you need to devote much thought to those things? Nah, you just sort of go on autopilot and you're thinking about what you're going to do that day or whatever you did last night, anything at all, because it's autopilot will suffice. It's only when we need to introduce some kind of creative response, that is a volitional intentional act, that we need the frontal lobes to basically suppress what has been the basal ganglia mechanism, but now is this mix of input from post-central cortex and orbitofrontal cortex and all these elaborate mechanisms we've developed in our cortex, like working memory and volitional attention, volitional vigilance, that provide vastly more power and subtlety to the way that we regulate sensory input and weed out what's not pertinent at this particular time and zero in on what is pertinent. So I've made the case that the basal, at least the sensory motor basal ganglia in humans is an anachronism. We don't use it. Now, neurologists always cringe when I say that, but back in the 90s, radiofrequency lesioning of the posterior inferior globus pallidus came back again after many decades of being ignored. And there was, even with the refined stereotactic technique, every once in a while, they managed to lesion right dead in the middle of that little edge. We're talking about a structure that's about a little over a centimeter on a side. So they had to nail it right in the middle. And every once in a while, they'd nail it. And I still remember it was a case reported by Jerry Vitek, who worked with Malin DeLong at Emory. And this woman, she had the lesion. Clinically, she was perfect. No more Parkinsonian symptoms and no negative consequences. Now, she was never studied in great, laboratory detail, but clinically, she looked fine. It's kind of, and I looked at that case and I thought, well, there you have it. We don't need a basal ganglia. And I asked Jerry Vitek about that case at a subsequent meeting, and he said, yeah, I think you're probably right. So in us, at least the sensory motor, the dimensionality reduction that is achieved by sensory motor basal ganglia is largely anachronistic. But this structure has been a workhorse going all the way back to creatures as primitive as Drosophila. And you probably didn't think Drosophila had a basal ganglia. They do. It's just a single ring of neurons that circle the thalamus, but it's doing its thing. So, and Drosophila has 100,000 neurons in its brain, but has a fairly fancy repertoire of behavior. Now, what about the ventral striatum, the ventral head of caudate and nucleus accumbens. Well, they have the same structure, the same cellular structure, but we don't have a human model of that, because even in advanced Parkinson's disease, the amount of dopamine depletion in those structures is only modest. And by that time, most of those patients are demented from cortical pathology. So we just don't know. We don't have a human model of disease of these structures. And presumably they are doing dimensionality reduction, but what dimensions? Their connectivity is all with various parts of the frontal lobes, but we just don't really understand that. And maybe that we really do need those structures. They haven't become anachronistic. So the general theme here is that by the time we get to Homo sapiens, we've undergone tremendous corticalization of structures that were subserving important purposes through much of evolution. And that's where we come full circle back to the amygdala. You know, is the amygdala still enhancing all of our brain function and serving as some basis for our emotional function? And the answer is we don't really know. We don't really know the answer to that question. But I think more generally, it might help us to sort out how the brain works by realizing that all of us in our heads carry structures that started evolving the best part of 1 billion years ago. And through all its advancement, some of it may just have become baggage that serves no useful purpose. But if it goes on the fritz, like in Parkinson's disease, then we're in deep trouble. So conclusion, orbitofrontal cortex, medial and lateral, subserves encodes our knowledge of subjective value. PDP has enabled us to understand that any concept represents engagement of multiple attractor basins. And in this talk, we're pointing out that that includes orbitofrontal cortex. That's just as much part of, and I've mentioned it briefly in talking about the limbic representation of dog, our feelings about dogs in general and our own pets. So we can think about attractor basins in orbitofrontal cortex, enabling representation of the entire spectrum of emotions, and orbitofrontal cortex sensibly connected with dorsolateral frontal cortex, and between the orbitofrontal cortex and postcentral convexity cortex, we have the objective and subjective knowledge that are weighing in simultaneously to help us compute plans for action in dorsolateral frontal cortex. We talked about the right hemisphere is largely a Gestalt processor, and the left is substantially a serial processor, but I don't think it's that simple, but that's about as far as our understanding goes right now. So damage to right hemisphere convexity cortex produces disorders of emotional recognition, whether it's in emotional faces or the affective component of spoken language, and anterior lesions of anterior right convexity cortex produce problems with producing emotion in our facial expressions and gestures, and problems with expressing emotion in our spoken language, and damage to the right orbitofrontal cortex is what we see in the most common form of behavioral variant orbitofrontal, behavioral variant frontotemporal degeneration. I introduced this idea that right orbitofrontal cortex is supporting predominantly reactive emotions and left proactive emotions. It's just an idea. We've visited the James Lange theory and said, yeah, basically correct, but incomplete. We've got to introduce orbitofrontal cortex as a player in this mix. So the last 3 slides here are going to be about depression, and I won't pretend that I have some kind of fully comprehensive understanding of depression. So I'm going to throw out some separate and not mutually exclusive ideas that maybe will give you a slightly different way of thinking about depression and the neurogenesis of depression, in ways that are useful. So one idea is that if we think in terms of the attractor basins and orbitofrontal cortex, in depression, the balance has been shifted to lateral orbitofrontal cortex with a consequence of negativity in everything. Value judgments about perceptions, memories, activities, plans, interactions with others, guilt, hopelessness, pessimism, all these various features of depression. Now, why? Why has this balance been or lack of balance occurred in people with depression, and some people in a horrible way, so that depression becomes almost refractory to anything we do. But all of us have bad days now and again, and at least, so we've all experienced some depression. So what is it about? What experiences ended up with that particular wiring of orbitofrontal cortex that makes some people more susceptible to profound depression? And we could cite a lot of things. Nobody that I've seen has really translated them into this idea of encoding within orbitofrontal cortex, but certainly we know, any clinician knows, that adverse childhood experiences can have a profound effect on people that endures throughout life. Similarly, experiences that induce PTSD, and they're not all military. There must be some genetic and epigenetic influences here. And we could even usefully think of this miswiring as a reflection of pathologic learning. So I'm taking learning in the purest sense, just alteration in neural connectivity. We think of all learning as good. And, hopefully what we're doing here in this conference, it's all good. It's all good. But there are some examples. Probably the best example is repetitive motion dystonia. How many people have heard that term? So this is a disorder that has ruined many career of pianists and violinists. So picture a concert pianist rippling down 30-second notes, and all of a sudden their hand goes like that, and boom, they're dead. They're dead in the water. It turns out that people have developed some methods of rehabilitating those folks. And we have good MEG studies of what exactly happens, particularly in somatosensory cortex. We see where the representations of the fingers are normally quite separate. In these people with repetitive motion dystonia, those representations overlap. So, why does this develop? Just through this repeated endless practice, somehow things go awry and we get pathologic connectivity. Kindled seizures is another example. We teach rats to have seizures, and we really do. I mean, that's what we're doing. We're teaching them to have seizures. There's reason to think that chronic pain may involve some pathologic learning mechanisms. We don't understand these things in any kind of fundamental way, but I think nonetheless they might be useful in thinking about how people develop these very deep attractor basins over the frontal cortex that translate into very severe and refractory depression. So one way we might treat that rather directly is to rewire OFC and its connectivity. And how might we do that? Psychotherapy. That's what we're doing. We're conveying knowledge, we're changing connections, and potentially rewiring and effectively treating depression. And we know from lots of studies that that works. Okay, how about thinking of this, and it's a completely other, potentially largely orthogonal domain, thinking about this as a pathologic imbalance between an input from postcentral cortices and orbitofrontal cortices. And what tipped me onto this idea of thinking about it is actually psychosurgery. And back in the 20s and 30s, and even 40s, psychosurgery was very widely done in this country. And in fact, in 1939, Egas Moniz received the Nobel Prize for his work in psychosurgery. So that tells you how important it was. And if you think of the psychiatric world before there were drugs, before there were any drugs, what did you do with these people? So desperate measures is what it boiled down to. But gradually, the bad consequences of that surgery became apparent, and it got narrower, and the domains of problems for which it was used shrunk and shrunk until we finally came down to this operation called orbitofrontal undercutting that I think William Scoville had introduced. And basically it involves damaging white matter connectivity between orbitofrontal cortex and dorsolateral cortex. So in other words, we've got this problem where these poor patients are basically slaves to their orbitofrontal cortex, which are spewing nothing but evil. And we kind of tip the balance in the other direction so that input from postcentral cortices becomes a little more relatively prominent in the mix, and these people can start to function, and if they're functioning, it's going to be therapeutic. So that's the general idea, and this is still an area of active research, not a neurosurgical operation, but DBS of accumbens, for example, or of ventral anterior limb, ultrasound destruction of stereotactic ultrasound destruction of ventral anterior limb. So this may come into clinical practice, even though it was a rather draconian operation. And this is my last slide, and I've entitled it the serotonin conundrum, because I'll tell you, you look at the serotonin system and you think, Mother Nature must be kind of smiling that she's finally posed us a problem that we hotshot scientists will never be able to decipher. I mean, here we are talking about 14 different serotonin receptors in 7 different classes. Some of them move around. They're altered by a duration of serotonergic input. I mean, it's a mess. So I've suggested here, I singled out the 5-HT2C receptor only because it appears to be more than usually dense in all of these limbic structures. But is this correct? Heck, I don't know. And I've pounded this literature and nobody seems to have an idea. And furthermore, most of the experiments, in fact, essentially all the experiments are looking at behavioral response to acute stimulation. But as we know, with depression, typically there isn't an instantaneous response. So what we're looking at is whatever changes have been created in these limbic structures as a result of sustained alteration in serotonergic input. So it's a real puzzle, and tells me that we're missing out on a really important development, because drugs like the tricyclics, the first was amitriptyline, 1951, and now of course SSRIs and SNRIs and bupropion. I mean, they've just revolutionized treatment of depression, and I now view it as almost always a fully treatable disorder. So surely there's a clue here. Questions?
Yeah. Yes, go ahead.
You mentioned the nuclear accumbens and sort of some uncertainty about its role. I wondered on your opinion about its role as kind of one of the key mediators of anhedonia in depression, and whether you think that affecting addiction, the kind of overlap of depression and addiction.
Well, it's a terrific question, and I'm only going to answer it somewhat indirectly. First of all, I think we need to conceptualize all of these problems as systems dysfunction and computational errors. We now have good reason to understand